I'm myself Dr. Mahendra Kutchatkar. I'm a national ATLS instructor, also the past president of Indian Foot and Ankle Surgeon. Now, this course basically starts with having three main guys in the course. You have the course director, you have the faculties, which are all national IP level instructors, and there's a course coordinator because a lot of effort goes into getting all the arrangements done, lots of mannequins and sort of simulations. Now, what are the objectives? Basically, it's to demonstrate the concepts and principles of primary and secondary patient assessments so that you are able to manage the treatment and prioritize in the initial hour, the golden hour. And initiating this primary and secondary management in a very timely manner is the key. So, in a given trauma simulation, you should be able to demonstrate the skills that are often required in the initial assessment and treatment of these patients. Now, generally when the ATLS course goes on, we generally have to introduce ourselves, because ATLS is taken by lots of different types of doctors. We have the general surgeons, you have the orthopedic surgeons, we have the maxillofacial surgeons, ENT. So whoever is involved in trauma management could come for this course. And irrespective of what is your professional background or what is your experience, this course is definitely going to help you. Now, when we say it's a safe learning environment, what do we mean by that? It simply means that it is so interactive. Though there are didactic lectures, they are not a standard lectures where, like now, how I'm sitting down here and just giving you a lecture. It's so interactive that gradually you start unfolding a case discussion. You start asking stimulus questions to each student. And the whole key here is that participation is required. And we respect each other because we understand that we come from different backgrounds, we're not supposed to know everything. And we try to answer the questions even if the things go wrong. A classic situation will be something called as MIST. It stands for M for mechanism of injury, I is for the injury itself, S for the stats, and T for the treatment that is given on the site of accident. So generally when the patient comes in and the paramedic brings him in, this is what is going to be provided to you. A 43-year-old male who has a driver, which is a motor vehicle accident, head-on collision with truck. Now, when the words head-on collision, it means that so much of transfer of energy has occurred. It's not just a simple information. Right-sided bruising, abrasions on the chest. Abrasions on the chest for an orthopedic surgeon has become such a small thing. But one small abrasion on the chest simply means this guy could be having a pneumothorax. A deformed right leg, yes, it does definitely excites us because we know now we have a fracture femur on our and we can fix it. But that's not the point. We have to watch his airway. So he is non-responsive. This patient is non-responsive. That means he is not alert. That means typically either he is having hypoxia or he is having head injury. Respiratory rate is 30, which is high. Heart rate is high. BP is low. Now that's been basically patient is in hypovolemic shock. And patient has been treated on a spine board with a C-spine collar. Now, ATLS provides one acceptable method for the safe and immediate pain management of the trauma patient. Now, each and every word here is important. One is that it's so standardized that all over the world, every patient is treated in the same way. So, it is acceptable. It is like, your AO classification. Like if you want to describe a fracture, if you just say a particular fracture femur with D2, C3, that way the information goes in very standard. And immediate. We don't waste time. Time is the crux in ATLS. So you assess the patient's condition rapidly and accurately. Resuscitate and stabilize the patients according to the priority. Now what is the priority? Airway can kill you before breathing. Breathing can kill you before circulation. And circulation can kill you before disability. So controlling the airway is your first chance. Determine whether the patient's needs are more than what you can provide at that facility and arrange for a transfer and indicate it. This is one of the key lessons in ATLS. You don't hold on the patient back. That immediate transfer to a higher center is very, very crucial. So what are the objectives of the course? Is to demonstrate the concepts and principles of primary and secondary patient assessments, establish management priorities in the initial management of trauma patient, initiate the primary and secondary management of a simulated trauma in a timely manner. It is not about doing it like as soon as the patient comes, we will just do a simulated case after this lecture to understand what is to be done first. And you have to demonstrate all the skills that are often required in the initial assessment. Like you should be able to do a FAST. FAST is a focused assessment of sonography in trauma. You should be able to do that as an orthopedic surgeon. You should be able to put in a needle, a cricothyroidotomy, and save the patient's life. You should be able to put a chest tube. So once you have done ATLS, you will be able to save the patient's life. And that is so crucial. So why is this need? Because 5.8 million people die every year from unintentional injury and violence. More than 9 people every minute. And that's the amount of trauma load. Injury accounts for 18% of world's burden on disease. Motor vehicle crashes alone cause more than 1 million deaths annually and 50 million significant injuries. And in India, it's like a death trap on the road. So ATLS provides a common language. And this story all started when John Steiner, is an orthopedic surgeon, was flying his private plane with his 3 kids and his wife. The plane crashed and his wife succumbed. And his 3 kids and he himself, they survived. But the treatment that he received was so pathetic that, he, in his own words, he says, when I can provide better care in the field with limited resources than what my children and I received at the primary care facility, there is something wrong with the system and this system has to be changed. This is the guy who started ATLS. He got 4 or 5 guys together and just brought the thought process. So simple things like this can be done. And you have to understand there is a trimodal to bimodal distribution. There is an immediate death on accident. You can't do anything about it. Then there is an early death. That is the golden hour. And then there is a late death due to sepsis or due to the SIRS. So ATLS concept is all about following the APCD approach to evaluation and treatment. Treat the greatest threat to life first. Recognize the definitive diagnosis is not immediately important. You don't need to diagnose everything, except that you have to be able to diagnose a pneumothorax, because that can kill the patient. Understand that time is of the essence and do no further harm. So ATLS concept is airway with restriction of cervical spine motion, breathing and ventilation, circulation with hemorrhage control. Disability is to look at the neurological status, expose the patients, and also look at the environment, because hypothermia is one thing that can kill the patient. So if you just remember this one slide in the entire presentation, it's more than enough. So this is how it goes out. I will go to the next slide slowly. Now, international ATLS programs goes on in 83 countries. In 3,380 courses have been done. 68,000 students have already done this. You also have an app available. You can download that. And documented improvement in the care of injured patients has been seen after implementation of this program. So it's just not an ATLS course. It has got implications. Organized trauma care resulting in reduced injury and mortality and retention of organizational and procedural skills. So summary, ABCD approach to trauma care. Do no further harm. Treat the greatest threat to life first. One safe way and a common language. So let me get to the next presentation. Yes. It's that ATLS is not a very mentally stimulating thing to the orthopedic surgeon. That is reflected by the fact that we don't have a crowd. They said, what is ATLS? Even when I did my ATLS, it was because the hospital management said, it should be done. But what I got out of it was more than gold. Now the initial assessment is so important in ATLS. It's vital in the golden hour, because that's where the first impact of death occurs. And we generally have the MIST, which is the mechanism of injury, the injury itself, the stats and the treatment. Then you do a primary survey. And always remember that in the primary survey, it's a dynamic survey. That means if you have done airway control, you have to go back and see whether that airway control is still okay, and for that, putting in the pulse oximeter is important. So constant understanding of that everything can change in the trauma situation. Just because you have put in IV lines, it doesn't mean that the BP will come up. You've got to monitor it. Go back, go back, go back. So primary survey, ABCD is the cornerstone of initial assessment. Repeat the primary survey frequently to identify any deterioration in the patient status that indicates the need for additional intervention. We have to explain the importance of preparations prior to trauma. Because when you get a phone call from the paramedic saying that so-and-so patient is coming, in your mind, you should mentally get everything ready that is required. That is your intubation, whether the laryngoscope is working or not, whether the battery is there or not. All these things have to be checked. Whether the IV fluids that you are having are already warmed up or not, whether you have a blanket or not. Simple, simple things. Whether your Thomas splint is there or not. So you have to be mentally prepared before the patient arrives. And once you have heard of the mechanism of injury, that is the key. If there says a high velocity accident, the person has taken a long time to get extricated, there has been one death in the car. What does it mean? It does mean this transfer of so much of kinetic energy from the car of the impact to the patient or the occupants of the car that your possibility of having polytrauma is very high. Evaluate the mechanism of injuries, identify the correct sequence of priorities for the assessment of the multiple injured patients. Apply the principles of primary and secondary service to the assessment. Discuss the importance of re-evaluating the patient who is not responding appropriately. And that is where you have to go back again and again and look at it. So this is the classic scenario. 18-year-old male, unrestrained, that means he is not wearing a seatbelt, driver goes and collides against a tree. Injury is not reported, vital is not reported, but what has been told is that it took such a long time for him to be got out. So what is the bell that rings you here? That is prolonged extrication. Chances of having a compartment syndrome, because leg might have got trapped. And some basic treatment has been given. Now how do you prepare for this patient? So you have to be aware that this polytrauma patient could be having a fractured pelvis, whether you have the sling to put it, or whether you have any other modalities. What are the facilities available in your hospital? Whether you have a CT scan, whether you have an X-ray. You have to get everything prepared, and once you have understood the mechanism of injury, you prepare your mentally what are the possible patients. Now when the patient arrives, initially the patient is lethargic, mumbling unintelligibly. That means patient is definitely in a semi-comatose type of a situation. That means either he is drunk or he has head injury. And both situations will be detrimental for maintaining the airway. So this patient will definitely need an airway control. And that is what the information is. See, we as orthopedic surgeons, we have gone through residency, we have gone to the casualty. Our approach is to go straight to the limb and not to the head. ATLS teaches you to go to the A, B, C, D. Because fracture femur or any other compound fracture there, it will not kill the patient. But if patient is not breathing only and you are trying to put a splint, then that's the end of it. A patient has facial injuries. When patient has facial injuries, you will think, isko to maxillofacial ke paas bhejne ka. The fact that patient has got facial injuries, is he able to maintain his airway? So this is the key. This is how the thinking process has to change. And based on this information, you have to also see what sort of interventions you can and are capable of doing. Which patients should be immediately transported to the trauma center. So that doctor who is treating this patient has to understand what is his limitations, to what time he can hold him, and what sort of information he is supposed to give the consultant on the other side. So this transfer of information and decision to transfer without wasting time on investigations like CT scan and this. Never transfer any patient for any investigation till the patient's airway is controlled and breathing is stabilized. And you have controlled the hemodynamics. Because everything else, because what happens is that generally patient आया, polytrauma, you have seen the deformity, so बोलो patient को X-ray को भेजो. X-ray को कैसे भेजेगा? Patient को, and this is become because, and if you are an orthopedic surgeon, you think that you can deal with trauma. You are not dealing with trauma, you are dealing with a patient here. And this patient has the ability to die in front of you, let me tell you. So these are the parameters: 120 BP, heart rate, BP is 90 palpable, respiratory 20, oxygen sat is 82, temperature 35.5, that means already hypothermia. So hypothermia is something that can kill the patient, and your treatment will not work if you have not warmed up the patient. So putting in a bear hugger or putting blankets, giving warm IV crystalloids is the key. So what are your clinical concerns? Your clinical concerns always should be to save the patient's life, and the limb comes later on as an orthopedic surgeon. And what are your management priorities? That means the airway comes first, breathing comes second, and then comes the circulation. And then comes D, that is disability, and E is environment control. Environment control means keeping the patient warm. In primary survey now, what has revealed? Obviously there is a facial trauma and mumbling incurrently, decreased breath sounds, left side of the chest, no visible neck veins, minimal bleeding, open left femur fracture, left chest bruising, possible pelvic fracture. Patient does localize to pain in the upper extremities, but does not open the eyes. So understanding the GCS immediately, GCS should be, EMV should happen immediately, because if it's less than 8, your chances that this patient is going to deteriorate very fast. So now patient has been intubated. So your first thing is chin lift, jaw thrust to maintain the airway. Suction, clear the airway, look for the saturation. If it improves, fine. But if the patient has got an injury, if it is intoxicated with alcohol, you are safer to intubate the patient. So once you have controlled the airway, then comes your breathing, then comes your circulation. Then you can put your splints and everything else. And giving in those warmed crystalloids is very important. So patient's vitals have slightly improved. Patient begins to respond to verbal stimuli, opens eyes, but still, tries to brush away your hands. What additional adjuncts would you do? Now, once you have put in the airway, and once the patient is stabilized, then you can send the patient for a chest X-ray, a pelvic X-ray, and a fast. That is when you think that the patient, now you can't send, you can do that in the casualty itself. And when should the transfer occur, and what tests are necessary before transferring the patient? So don't waste your time doing things that doesn't matter, like a CT scan. It is not important. Because even if you see a CT scan and give a diagnosis to the neurosurgeon who is there about 10 kilometers away, what are you going to do about it? It doesn't matter. Now here, as this case progresses, patient's LOC decreases, patient opens his eyes to pressure, moves away from stimulus, there's normal flexion. Vital signs, again, heart rate is 100, BP 100 by 60, but breath sounds are bilaterally good. So airway is under control. Pupils dilated, laceration is there is left hemotympanum, large ecchymosis, left anterior chest, abdominal is soft and non-distended. That means he has an obvious chest trauma, but abdomen is fine. Now this is when a patient's things changes, you should immediately start looking at whether you need to add one more IV line. So we'll come to the case scenario, and Dr. Avinash will help me. There is no neurosurgery on site, so your decision has to transfer this patient as early as possible for definitive care. Contact the family. The family insists that you have to get a CT scan of the head. But if you feel that this will delay the obvious treatment that is required, then you must emphasize that it is about saving the life rather than getting to a definite diagnosis. So ATLS is not about definitive diagnosis, it is about saving the patient. So patient is transferred. Now once you go through this presentation, what you will realize that the importance of preparation of prior to trauma arrival, patient arrival. Evaluate the mechanism of injury and trying to build up that story in your brain. Identify the correct sequence of assessment. Apply the principles of the primary and secondary surveys. Re-evaluating for a patient who is not responding, and recognize the patients who need an immediate transfer. So coordination with hospital providers is important, preparing for the receiving the patient is important, and anticipating the injuries based on mechanism of injury. So on that phone call, these three things have to work in your mind. And evaluation of all trauma patients follow a precise algorithm. So ATLS is all about algorithms. It was about standard operating procedures. Patients who exceed the capability of the institution should be identified rapidly, and transfer has to initiate. Thank you. So I would now request Dr. Ashwin Joshi to start the case. So this is basically like a mock drill. We'll just imagine that there is a patient here, which I think I will ask you to do. What you need to do is, you are the trauma patient, okay? And what you have to show is that you are breathless. That's all. Can I have a hand mic, please? Yeah, you can start your.
Yeah, very good morning to all of you. We'll be presenting a clinical case scenario wherein we'll be attending to a patient who has suffered a fall from a height. I'll be the ortho resident at a peripheral hospital, and I'll treat the patient just the way most of us who haven't done an ATLS course would treat it in any government hospital's busy casualty. Mahendra sir would then elaborate on the manner in which this patient should have been evaluated, stabilized, referred to a higher center, as it's beyond the peripheral hospital's capability to handle this patient. What he sees in that patient, which we don't see as ortho residents or those who haven't done a ATLS course. He'll take us through the various points which we usually miss. So mechanism, he is a 30-year-old worker who has had a fall from height of about 35 feet or 10 meters. His helmet has come off upon impact. The patient is unconscious. His left thigh girth is more, that is the thighs are asymmetrical. Stats wise, BP is on the lower side, 85/60. Heart rate is 100. Respiratory rate is on higher side, 24. The patient is responding only to pressure, stimuli and pain. As an ortho resident, I am excited to see that the thighs are asymmetrical. That means suspected femur fracture, I'll get a cutting.
So now what he has, his focus as an orthopedic surgeon
Is directly on the left thigh.
is on the left thigh. So he has not told me anything about the airway, whether the patient is breathing, whether he has put in a oxygen monitor to look at the stats. So this is the first mistake, that when the ortho resident walks into the casualty, initially this patient is suppose here is he's gasping, right? So if he is gasping, that means either he has no control of his airway, or he has had chest trauma, or he is having a head injury, or he is having alcohol intoxication. Now all these things are possible. Now my aim is first to, what is the procedure to be done? Can you tell me now, what would you do?
Looking at the deformed thigh, I call for a TT splint.
Yes. So orthopedic surgeons is happy. He is happy that he has put a splint. He has immobilized the patient. Patient is gasping, right? So, Dr. Joshi, what you are going to do next now? This patient's oxygen saturation
I've
is
called
82.
for a TT splint. I've asked for a IV bore cannula, large IV bore cannula, and जो भी है NS या RL जो भी है फटाफट लगा दो.
देखा? This is the standard. He is telling the nurse, push in more IV fluids. But doc, this patient's saturation is 82. What are you going to do about this patient is gasping? He's become irritable.
I'll start oxygen on 5 to 6 liters.
Yes.
With the mask.
And what has happened? The oxygen saturation is still 82. What are you going to do next?
You have to evaluate the airway.
Yes. So what are you going to do by evaluating the airway? What is the first maneuver you're going to do?
Chin lift and jaw thrust.
Yes. So this is a very important maneuver, chin lift jaw thrust, because that will, the fallen tongue which is back will get lifted up, and that is probably enough. Yes.
Can you once show properly, just maybe how to do a good chin?
Yeah, we will do it immediately after this. That's it. No problem. He has done the chin lift and jaw thrust, but still the oxygen saturation has not improved. What next?
Because
Doctor?
in our government setup, doing anything beyond this would mean making the other patients wait, and there is a chance of tempers to easily soar in the casualty. So I decided to admit this patient.
See what he's saying. He is worried. What is happening outside the casualty, and there is a crowd outside.
So I've admitted the patient with this preliminary treatment.
He is under pressure. He wants to admit the patient.
Thinking I'll get his fitness done and I'll operate him for femur.
So this is how a ortho resident's mind works. That he is worried about getting this surgeon's patient fixed. What is he going to operate on, the dead patient? So airway control. Okay. So jaw lift chin thrust has not helped. What is your next step?
And I have missed so many points which sir will take us through now.
Okay, right. So now he has not able to stabilize. So automatically, if his patient is not able to hold it, you are not able to stabilize it, you need to do some procedure which will be able to sustain his airway control. That is to rapid intubation is the key. Okay. So now Joshi has understood that he has to save the life of the patient. He has intubated the patients and the oxygen saturation, and plus he has attached the oxygen high flow, and oxygen has now saturation is coming up. What are the other injuries that you have seen?
Rapidly I examine him head to toe, and after that I realize that he has blood at his nasal orifice, water in the ear, external auditory canal.
So now
the consciousness is reduced.
Rapidly, this is part of the initial assessment. Ear blood, hemotympanum. So that means fracture of the base of the skull.
Respiration is rapid and
shallow. Okay.
Consciousness is on
Plus,
the lower side.
what else did you miss on the chest? What was there on the chest? Did you examine the chest of the patient?
Rapid and shallow respiration.
And what else was there? Was there any bruising?
Abrasions were there.
Yes. So chest abrasion on a patient with polytrauma is not a small thing. For an orthopedic surgeon, it really doesn't make a difference because, thoda kharoch hai. But chest trauma, that means patient has either some problem in the mediastinum or there is a pneumothorax, and patient is respiratory rate is not, and the heart rate is not picking up. So patient's heart rate is now 120. What have you done?
I have secured one single IV line and I have pushed in couple of RLs.
That's not helping him. What else? What else we think you should do? What is the standard of care in a casualty situation for bleeding control or management of bleeding? Closed injury. He said IV line single. It is two wide bore lines with warmed crystalloids. See, this is like a line. It should come like a sequence, tuck.
And assuming there's nobody wide bore means like
18 gauge.
18 gauge, sir.
18 gauge, 2 needles, warmed crystalloids, and that's what is the treatment for a concealed bleeding, right? So he has done that. Now heart rate is slowly getting better. So what else? What patients? What is the oxygen saturation again?
80ish.
80 it's improved. So why I'm asking this question is that if you have secured the airway, doesn't mean that it's done for life. Go back, check airway, come back to breathing. A, B, C, C, B, A, keep on because it can change. Just because you have intubated doesn't mean that patient will be fine. So now patient's heart rate is fine, blood pressure is a little stabilized. What more investigations would you write right now?
Immediately send blood for basic testing.
Yeah,
all
grouping,
routine.
cross-matching.
Yeah,
Then
ABG,
ABG, very good. Why you want to know ABG for what?
saturation.
Saturation and acidosis, because acidosis is going to kill the patient. If his patient's, again, because the whole chain of trauma starts the inflammatory response syndrome. What else?
And
What
putting
X-rays would you ask for now?
Chest X-ray, pelvis X-ray,
Yes.
and limb X-ray, which I'm
Yes.
suspecting.
So limb
Suspected
X-ray you can
femur.
hold on, but chest and abdominal X-ray, that is pelvic X-ray.
says fine in cervical because of head injury.
So if the patients, see it is like this, if the patient has a cervical spine injury, it doesn't matter because you've already immobilized it. When you are doing the chest X-ray, you can ask for a lateral cervical spine. But it is not going to kill the patient, right? So it's prioritizing the treatment. So it's a good question that you have to do the X-ray cervical spine at some stage. But yeah, X-ray chest is important. So X-ray chest ka finding kya hai? What did you find on the X-ray?
Showing a widened mediastinum.
This is the key. This guy's mechanism of injury is fall from height. Deacceleration injuries like aortic rupture. Right? That's why he's not getting stabilized. A fracture femur mein kitna bleeding hota hai? So this is what is important to understand. If your treatment is not making a difference, that means something more is happening to the patient. Obviously, fracture femur 1.5 liters cannot kill the patient and cannot get your heart rate so high. So this is the key, that understanding the patient's entire transfer of kinetic energy into the chest, into the abdomen. So widened mediastinum, so the bell rings, so now he's scared. Now he knows, now this is beyond me, right? Pelvis is normal, fracture femur is there. So now his mind starts...
ENT bleed is also there. So
Sorry?
that is definitely beyond us. ENT bleed.
So ENT bleed is there, that means that head injury is there. So it means that basically he is not now worried about saving the patient's life, he has intubated a patient. Now the thing is he is worried about definitive care.
Stabilizing and referring.
So he has to now speak to the consultant, give this information and start for an immediate transfer. This is all ATLS is all about. Save the patient's life, do what you can to save the patient's life and transfer. Don't waste time doing investigations which are irrelevant.
These patients come with drooling of the mouth or something in there. We don't know how to intubate.
Yeah.
There is a suction.
So suction is a
Used or not to
absolutely to be used. Suction, but you have to be careful about what?
it induce a gag.
No, base of the skull. Don't put it too much inside. Go through the preliminary form. You can suck. You have to suck because sections aspirate, and you can't say I can't intubate. You should be able to intubate as good as an anesthetist after doing an ATLS course. So you don't feel sorry with just 2 minutes more, and you don't have to feel sorry about it because ATLS teaches you all those skills required to save the patient. You'll be able to intubate. You'll be able to do a needle cricothyroidotomy. You'll be able to put a chest tube. You'll be able to do a fast. Enough. You have saved the patient. And then you can go to a secondary survey, log rolling the patient, looking at fracture pelvis, looking at the other injuries, a rectal examination, putting in a gastric tube, putting in a urinary tube. all these things will happen simultaneously. But not putting them will not kill the patient. It is for a monitor.
All these patients where head injury or a cervical injury is suspected, we keep reading multiple times of what's the right position. So is it the sideline with the one leg up?
So it is inline traction with the body, and 4 people have to use to turn the patient. So one patient holds the head, inline traction, and then turns with the body. And they all occur together simultaneously. One log roll, and the guy who holds the head is the captain. So he tells roll. That he rolls and the guy holds the head, it's going to cause a rotation. Right? So I think
This is at what step? It's right at the beginning, first step.
C collar is already put most of the time by the pre-medics. How that is put, we do not know. But but when you're going for the airway, at that time you can do it simultaneously. Everything is simultaneous. It is not that iska pehle karo idha. Airway, A means airway control and C spine immobilization. Comes like that. B is breathing. C is circulation. D is disability evaluation. E is environment control. Right?
So now in Bombay, for an ATLS course, how do we know?
So ATLS is a website.
Right.
All over India. Now, like when I come from Goa, I have a ATLS center, and we have got 5 courses every year. So if you go on the net, you can book your course.
In Goa, sir.
Yes.
But in Bombay, would you know? Like,
Bombay also, you go, if you go on the ATLS site,
I think in Sion they conduct it very
Sion
frequently.
also is conducted.
Sion Hospital they conduct it very frequently.
Now, me as a pediatric orthopedic surgeon, there's still adults still somewhat people manage to some extent. But when a case is a pediatric type of case which comes for polytrauma, the residents don't even go near it because anyways their pediatric knowledge is quite less comparatively.
In the ATLS course, there's a separate chapter on
Yeah,
pediatric trauma.
Yeah, so the thing is that little bit part even no one knows at all because it's completely it's different as compared to what you would do in an adult. It's not exactly the
It
same.
is
One
not
thing-
exactly,
one
but
thing-
the principles
Yeah,
of
principles
saving
are
the
the same.
patient's life
Yeah.
is the same. What will change? Body volume will change.
Yeah.
Whatever you give in terms of body weight will change. Otherwise, airway control to karna hi hai. Lift has to be done.
The
Other
end of the
thing
day,
is,
the orthopedician will be the captain of the ship, but it has to be a multidisciplinary approach. You have to involve the pediatrician. You have to involve the pediatric intensivist.
So that is the thing. Like here, usually abroad, the ATLS teams, the anesthetist is the captain of the ship, and we are just one rung of the.
But what happens is, this is in an organized trauma care.
Yes.
You are a medical officer who happens to be an orthopedic surgeon.
Okay.
Then
Yeah.
what do you do?
Then you have.
Then you have to
be able
think like a trauma surgeon, not as an orthopedic surgeon, nor as a CMO. So trauma is about saving life and then saving the limb. So ATLS is not about getting you new knowledge. It is getting you priority of what you're going to do first. That's all ATLS is about. It doesn't teach you something great concepts. It's just about getting your mind thought process change.
conceptually, NS and RL, if it's first crystalloid, we have option of both. What makes more sense and why?
Giving ringer is supposed to be the safest thing because NS can change your electrolyte much drastically, especially you are having
then-
comorbidities.
Okay, and is there like this cohort of patients, like diabetic patients don't give RL or something like that?
RL is to be given straight away. It is
And if you have a wide bore cannula, so do we just open this up? Like what's
Rapid,
we have to push,
rapid,
right?
just
Rapid means it's just okay.
full flow.
Full flow. Okay.
You cannot, a guy who is lost 1.5 liters, you cannot overload him so immediately.
Got it.
पहला 2 लेने का, उसके बाद उसको assess करो. Then don't go on putting too much. Then packed cells come. Then you start the transfusion protocol.
Correct.
If the patient is bleeding, pelvic fracture, ये वो polytrauma है, then you start a transfusion protocol. That's a totally different thing. So you can't just giving crystalloids.
In that time, you got your matching done and all.
Yes, yes,
What
yes.
stage is this?
But let me tell you, very rarely you will see a patient with hypovolemia die in front of you. The airway guy is going to die. ATLS is about controlling the airway, controlling the breathing. Orthopedic का सर्जन दिमाग सर्कुलेशन से स्टार्ट होता है. एयर भी उसका कॉन्सेप्ट ही नहीं है.
Lower center में जो district level like you were saying.
हाँ.
So basically, as from your side, like they should just stabilize and refer
As fast as possible, absolutely.
Stabilize and refer.
Refer.
Sir, and then this
And
situation-
stabilize by prioritizing airway
Airway,
first,
yes.
breathing second, circulation third.
Circulation.
So we saw this case where we got the airway fixed, the saturation is still not improving, and then suppose there's a tension pneumothorax, or so how often have you seen a tension pneumothorax?
So in my career, I have killed probably one patient with pneumothorax that I think I knew. I don't know how many have died because of.
And you would have picked it up only on the chest X-ray. Like how would you pick it
If
up?
patient is gasping,
Huh.
so let me tell you.
So not think and just.
No, if the patient's airway, you check airway, na, right side में नहीं है. If there is a trachea is deviated, tension pneumothorax, put it on the needle. It's that simple.
Excuse
And
me,
you
sir.
can save the patient's life.
Another 5 minutes, sir, so
Yeah,
that we can
we're
proceed for the Talwalkar symposium.
Yes, we're done. So I think we'll just demonstrate it, jaw
Yes,
lift and
yes.
I think, thank you very much. Thanks a lot. Thank you
Thank you,
very much.
Dr. Kocherkar. Thank you, Dr. Joshi.
So now inline traction is what you can do. Is to hold here. This is how you immobilize the patient. Your hand here, so see, that is not moving. And if you want to give inline traction, that means just put your hands here and hold like that. Slight traction. Now patient is not, tongue is fallen, your tongue suction everything. What you do is put your hand under the jaw and lift it. Now he is, not allowing you to move away. You just lift this up in the corner. Up. Right? And then that way. Up will lift up the whole palate up with this thing. And then,
So a thrust is actually pushing.
yes, chin lift and jaw thrust. Lifting it up and this. And intubation is something that is, you have to practice. We practice it afterwards on our real cases when patients are giving GA, and it's all about giving recoil pressure, because most of the time when you're intubating, you can't even see that thing. So giving the Selix maneuver, it's called this. On the cricoid, you put a pressure, and you push the airway down, and you can see it, and then you go. But I'm telling you, putting a laryngoscope, putting a laryngoscope is one thing, it could be this patient at home. So if as an orthopedic, as a 40-year-old orthopedic surgeon with 25 years experience in joint replacement, if you're not able to, save a patient's life, it is so. And I felt, I must have killed so many patients in my life out of ignorance. It was long.
As soon as these guys come, when we are just, you always just open them out and check if there's something inside, clear.
Do a swipe, because so many times it's a denture. A loose denture could be there.
So I've had some like loose teeth here.
Yes, absolutely. So if you spend some time with your anesthetist when he's intubating your routine patients, what you will realize is that that you will learn a lot of things. So I think ATLS course is something that you don't. It is sad that people think that ATLS में क्या है यार, ATLS तो कुछ भी नहीं है. And I'm so happy that sir is here, because this shows the intent to get better. Like yesterday there was a nice lecture. He says, no, the competition should be yourself, not the guy next door. So if you've done ATLS course, definitely you'll be better than the other guy. Maybe in your lifetime you'll be involved once. But at once.
Save one life.
That will give you satisfaction for your whole life.
Most of us are thinking that forget for others, for our families.
You never
we
know.
should know.
Yes.
Even you can
Joshi.
be in that situation where you
Joshi,
can need to
picture काढतो का? So I think it's most important is you guys first do an ATLS course, and you will realize that how much better you are, how much confident you are, and you should not be feeling sorry कि अरे मुझे intubation आता नहीं है, मुझे chest tube डालना आता नहीं है.
It should be like it is abroad. So for there, if you're working in a trauma center, if you've not done this, you're not allowed to work.
No, it's a mandatory thing, and the MCI is trying to do it now. MCI is trying to make it compulsory for all interns. Starts at internship, and if you become an ATLS is not rocket science. Once you understood what an ATLS is, then it's just about practicing intubation. And why not? Why can't we?
Compulsory for all ortho residents, or even
Everyone.
all residents, not ortho.
And
For MBBS only, at least they should know all these basic things, because most places they are the ones who are there.
Correct.
In the real lower centers. Then
Very sad that as orthopedicians also we have a lot of YouTube videos which maybe
Yeah. There are a lot of memes.
But the intensivist said that patient has a systolic. So the anesthetist is like, okay. He's like, what? He's like, I want to operate. I want to fix I want to fix a fracture. But patient has a systolic. The patient has a fracture. I want to fix it. So it's a sad thing that
Yeah. With that.
it is.
So no, this is not about, this is universal. Huh? This is not about India. This can happen all over the world. It is not, let's come, let's come, let's come. Come, sir. Come, Rishi, come. एक पिक्चर काढा.
Yes, ready, look here.